Good evening, everyone. Good
Good
evening.
evening.
I'm
Good
really,
evening.
I'm really sorry. I was waiting for the notes to be shared, but I hope you can. I think we can start now. So just a minute. So my name is Katile Mutuku, and today we are on our session 17 of Building a Healthy Mother and Child Training. And our we'll have two speakers today, that is Anne Beatrice and Blessing Ituren, and will be taking us through danger signs in pregnancy, and Blessings will be taking us through hypertension in pregnancy. So I'm really sorry for us starting late, and I hope we learn. So because of time, I think we can start with our first speaker. We'll be speaking on danger signs in pregnancy. She's called Anne Beatrice. She's a nurse, a certified childbirth educator. She has love and passion of fighting against maternal and neonatal mortality, and I hope she'll tell us more about herself. Yeah, so welcome so much, Han, and sorry for keeping you.
Hello, Katile. It's okay. My name is Anne, as you have said. I'm also a reproductive health specialist at master's level. I've specialized in reproductive health and midwifery. So I think we can start because you're the one with the notes. Yes, our topic today is danger signs in pregnancy. So for the introduction, I'll just go through the slide very fast. The beauty of pregnancy is in its outcome, where we expect to have a healthy mother and baby. So whenever a woman is pregnant, from me as a midwife or the medical team, what we want to achieve by the end of the pregnancy is that we'll have a healthy mother and baby. Pregnancy is maintained by hormones, where from conception. Actually, the other time we were discussing preconception care. Way before conception, this is where we have the menses, what we call the periods. They are controlled by hormones. So even when we come to pregnancy, it's a matter of hormones. There are hormones that are involved in sustaining the pregnancy. We have a hormone that is called progesterone. We have a hormone that will come later in pregnancy that is called oxytocin that will help in delivery, in initiating labor and delivery. So the pregnancy journey is a journey that is much more controlled by hormones. Most women go through pregnancy without serious problems. It is possible. I know people, I have been there, and it's possible to go through the whole journey from conception up to delivery without suffering what we'll be discussing today. Even as we discuss the danger signs in pregnancy, there are some that are normal. There are some that we call physiological changes, and there are some that we call minor illnesses in pregnancy, which include heartburns. We have frequent micturition, which we also call the need to urinate often. We have mostly heartburn will happen later in the pregnancy because of the enlarged the enlarged stomach will tend to push onto it's called the cardiac sphincter. It's like a valve that closes the food, closes the upper part of the stomach. And so because of the enlarged abdomen, it will tend to open, and there will be some regurgitation of some acid, therefore causing heartburn. The need to pee frequently, it happens mostly in the first trimester, that is the first 3 months of pregnancy, because of the anatomical location of the bladder. Then the uterus will be sitting, the uterus which is growing with the baby will be sitting on the bladder. Then in the second trimester, the uterus becomes part of the abdomen, leaves the pelvic part and moves up. So the pressure on the bladder is a bit relieved. And then it will recur in the third trimester because now the abdomen will be heavy and will sit back on the bladder. Mild headaches is basically about hormonal changes, which will also cause breast tenderness and swelling, and also the feeling of tired. Definitely, it's because of the weight gains and many other changes in the body. There's also to ensure safe pregnancy, the following danger signs must be checked, and that is what we want to discuss now. Second slide. Okay, number one, we will talk about vaginal bleeding. It's a cause of alarm, because as we all know, during pregnancy there should be no bleeding. Menses should cease immediately a woman is pregnant. In early pregnancy, spotting can indicate implantation bleeding. What happens once fertilization happens? Fertilization happens in the fallopian tubes, and so after fertilization, what is formed, it moves now into the uterus, and it implants. It's okay, layman's language, it plants itself in the uterus, but medically it's called implanting. And during this implantation, it kind of erodes. It's like the way we plant a bean in the soil. You see, there's some soil that will pull out. So the same thing happens during implantation. There will be some kind of eroding of the uterine muscle, and this will cause some bleeding, little bleeding. Some women will experience it, some will not even notice it. Then first trimester bleeding may indicate, it could be an ectopic pregnancy. This will happen before 8 weeks, or it could be a miscarriage. A miscarriage is where now the abortion has happened, the baby has come out. Then another thing that could happen is that later bleeding can be due to miscarriage. Again, miscarriage can happen in the first trimester and can also happen in the second trimester. There's also something else called placenta previa or placenta abruption. I'll explain this better with using some images later. Infections may also cause bleeding. And remember, we are talking about vaginal bleeding. So these are infections that could involve the birth canal, and especially any infection that will cause some erosion on the cervix. Notice if any of this bleeding is noticed, then consulting a doctor or a midwife is very, very necessary. Because remember, as I started by saying that any bleeding, and that is vaginal bleeding, should not happen during pregnancy. We continue. Then I talked about placenta previa as a cause of bleeding. The signs of placenta previa, number one is that it's heavy and then it's bright red. You see that blood that color of blood that you see when you've cut your finger, that is what you will see. Then it's painless. It's painless bleeding. Unlike the other one that you'll see, this bleeding is painless. You see that there is a flow of blood. You can see that the pad is very wet, but it's painless. Then it begins suddenly in the last few months of pregnancy. We'll see why. Then happens when the placenta covers parts or all of the cervix. You'll see in the image that you see after this. Then can cause severe bleeding and can be very serious for the mother and baby. This is because of depending on the magnitude of the tearing of the placenta and how big or how much it is covering the cervix. Okay, it can cause severe bleeding and can be very serious for the mother and the baby. We know why, because bleeding, blood is life. So if the more we lose blood, the more we are causing this mother to be anemic, and of course the less that is taken to the baby, because whatever the baby feeds on, in quotes, is what the mother is delivering to the baby in the utero. Then hospital admission is necessary if the bleeding is heavy until the mother and the baby are stable. If the bleeding stops or is light, bed rest is continued until the baby is ready for delivery. If the bleeding does not stop or if preterm labor starts, the baby will be delivered via cesarean section. The reason why the baby will be delivered via cesarean section, you'll understand it better using the next slide with the images. We continue. Okay, now these are the images. As you can see, we have 4 types of placenta previa. If I start with the first one that is called the complete previa. With complete previa, you can see the whole placenta. That dark part with the cord up there is the placenta. So as you can see, it is centrally placed on the cervix. The opening down there, you can come with the arrow down there. Yes, there. That's the what is called the cervix, and it's the part that opens big enough for the baby to come out. Now you can see there's something closing above it, which is the placenta. And remember, placenta is I usually say it's the second mother of the baby. So there's no way we can remove that placenta and expect the baby to survive. So if the placenta is completely lying on the cervix as seen in the first image, that means this baby has no way throughout. So this baby has to be delivered via cesarean section. And so what happens with this kind of bleeding is that the cervix will slightly open. And if it slightly opens, imagine what happens when maybe you are taking a soda, and when you open the soda, you see how it gushes out. So imagine now this is the soda, the inside is where the baby is. So any slight opening of the cervix will cause bleeding. And because it is the placenta that is peeling, then there is no pain. And that is why we say this kind of bleeding does not cause any pain. Into image number 2, where we have partial placenta, partial previa. You see how it is slightly covering. It's just at the edge. But remember the comparing. Now we have mostly the babies are born head first. Now you see with what part is covered by the placenta, it has reduced room for the baby to come out because the head is big enough. So with this kind of previa means the room for the room or the way for the head to come out is quite reduced. So even with that one, delivery might also not happen. And remember also with this kind, any slight opening of the cervix will also cause bleeding. To vaginal previa, it is just above. It's just above the cervix. It also slightly reduces the head of the baby. The room or the way out for the baby. If the baby is quite small, maybe a premature, it can come out. If the baby is term, then we don't allow the mother to deliver using this method. With the low-lying placenta, you can see it's slightly up. With this one, if the bleeding is not, it's not that we will allow the mother to deliver using this, but in some instances, if the baby is small, if the mother has done a scan and we are assured of the magnitude of the placenta previa, and also now looking at the size of the baby, we can allow the mother to deliver using even with this kind of previa. But still, remember, we don't want this mother to bleed, because if we subject a mother to deliver using this per vagina with this kind of low-lying placenta, any pressure as the baby is coming out will also trigger more bleeding. So that is why we said any mother bleeding because of placenta previa will not allow them to deliver the normal way, but will now push them to deliver via cesarean section. I hope I'm well understood, but there'll still be room for questions. Explaining the same thing, you can see type 1 is what we have discussed as the last. You see, at least that one, the head is kind of slipping through somehow. With type 2, you can see there is an arrest of the head up a little bit. With type 3, you can see the head is like 3/4 of the head is arrested. And now type 4, what has happened, it has even changed. It has caused a change in the presentation of the baby. Now, because it has reduced the lower part of the cervix or the uterus, there's no room even that can fit the head, because the head is the bigger part, the largest part of the baby. So the baby now has to sit, in quotes, to sit, but we call it breech presentation. So imagine what would happen if with type 4, the cervix is slightly opened. That mother will bleed profusely, yet there is no pain. We can continue. Now this is an almost real baby with some explanations. You can see the fetus, you can see the uterus, the umbilical cord, the placenta. Now you can see it well with this. Is this now the 3D image? And then you can see the cervix. Looks like a real one because of that muscle-like thing. So that's basically what I've been trying to explain, that with this kind, the baby will not come out, but at the same time, with this kind of presentation of placenta, or rather, or the positioning of the placenta, there will be bleeding. Remember, our subtopic is PV bleeding. So with this one, there will be bleeding, and therefore it is not good. It's a danger sign. We continue. Now there's another one we call placenta abruption, and this is where the placenta is well located in the abdomen, but somehow it peels off. Some percentage of the placenta peels off. And so there will be some bleeding. The mother will notice some bleeding. And this is how it is characterized. There's PV bleeding, mostly in the second half of the pregnancy. It's sudden, continuous, or cramping pain in the abdomen. Unlike the Previa kind of bleeding, with placenta abruption, there is some pain or some tenderness around the area where the placenta has separated. You expect some pain. There is tenderness when it is pressed on the abdomen. This means the placenta is breaking away from the wall of the uterus, and the baby may not be getting enough oxygen. Now we understand why, because whatever the nutrients that happen, okay, the placenta per se is the second mother, I had said that, of the baby. So whatever comes to the baby is first received by the placenta. And when it is received by the placenta, it is channeled to the baby through the cord, the umbilical cord. It's like the power in the house, and then there is a socket. We call the socket the placenta. Then you use your charger, you plug in, and then you get the power from the power from the main house through the socket, and then the charger being like the cord, and then takes it to the baby. Now you see there's some separation, and when the separation has happened, it has definitely reduced on the size of the placenta. So this reduction on the size of the placenta therefore means that there is little, that is the area that receives from the mother is reduced, and therefore what is also channeled now to the baby is of lower quantity. Causes of placenta abruption. Number one, it could be abdominal trauma. Another thing, multiparity. When we talk of multiparity, it's these mothers who have delivered maybe the 5th pregnancy and over. And then there's abruption in the previous pregnancy. If maybe in the previous pregnancy this mother had suffered abruption, it's possible that in this one it will recur. Not mandatory, but it's just a possibility. Then major congenital malformation. This is when we are talking about the congenital malformations with the baby. It can be a major cause. Pregnancy-induced hypertension. I don't know whether we have discussed already medical conditions, but these are a condition called hypertension. and sometimes it will be induced by the pregnancy, or if this mother has been having hypertension. She had hypertension prior to pregnancy, so we call it chronic hypertension. It can cause a separation of the placenta. Then smoking, cocaine use, because of what happens, the effects of cocaine and the cigarette smokes into to the blood vessels. It can cause this. We talk of early rupture of membranes. When the membranes rupture so early, and when we talk of membranes, when the baby is in utero, this that bag of waters. The baby is like a fish in the utero, and for that water to be held, there are some bags. It looks like a balloon. I believe all of us knows the balloon. So it's like a balloon, but inside that balloon, now that's where the baby is. So this balloon are the membranes, and they are two. So if they rupture very early, when they rupture very early, they can cause, as the amniotic fluid, which is the water in quotes where the baby survives in, can tend to cause the separation of the placenta. Then infections along this on the same membranes, which we call chorioamnitis, and then we talk of age above 40 years. Then if the separation is minor, also it will happen in degrees. It can be minor or major, depending on the cause at the same time. So if the separation is minor, resting in bed for a few days usually stops the bleeding. Moderate cases may require complete bed rest, and we said why? Because we want to manage this mother to make sure that she's not bleeding at all. Severe cases may require immediate delivery of the baby. The reason why we are delivering this baby is because we want, as long as the baby is in there, then that means that the mother will continue bleeding, and we might end up losing both the mother and the baby. So if the bleeding is severe, then we'll have to remove the baby, and sometimes you remove the baby aiming to save the mother. We can continue. Well, those are just images. I hope you can zoom and be able to see. Okay, you can see the first one. Yes, you can see the placenta. That is a very good one. But now you see the second one, the concealed bleeding. Can you see there where the pointer is? That is the placenta, but it has slightly separated. And what has happened is that there is some concealed bleeding. So unlike placenta previa, sometimes with placenta abruption, there will be minimal bleeding. But remember now with this one, there will be pain. There will be pain at the site of separation. So the mother will come to hospital complaining of pain localized at a certain place, a localized pain on the abdomen. And if the mother is sent for a scan, for an ultrasound, then we'll be able to see that there is separation. Others will come with slight bleeding. It may not be as major as in placenta previa. The greatest disadvantage with placenta abruption, what we are covering right now, is that the bleeding may be so much, but what is seen PV is very little. So we might think this mother is not really bleeding, but up there, as you can see, there is concealed bleeding. It is so much. So we can easily lose the mother thinking that she's not bleeding. Unlike placenta previa, where we are seeing this profuse bleeding, or we can be able to tell it was minor, it's getting worse. With this one, you might not even tell, because sometimes it can be concealed. But the good thing with this one is that there is pain. So we can tell when the mother insists the pain was light, it's increasing, meaning that the pressure is becoming more. Well, I think I've explained well. Number 4, sudden rupture of membranes. Premature rupture of membranes. Rupture of membranes is a danger sign it calls for doctor's examination, and there are many causes. There are many causes of premature rupture of membranes. Number one, pressure. The amount of pressure that is subjected to the membranes. Number one, it could be because of multiple pregnancy. When I talk of multiple pregnancy, I mean more than one babies. Could be twins, could be triplets, could be as many as 5. Because so these babies, and remember, there are the babies now there. There's the placenta, and then there is the amniotic fluid. So all this pressure, when it's subjected to the membranes, they can rupture. Another cause could be the waters. The amniotic fluid could be so much, we call it polyhydramnios. And when it is so much, it can also now cause the membranes to rupture. And another thing can be because of infections. Any infection through the birth canal, past the cervix, and to the membranes, we call it chorioamnitis. Then this infection will cause a weak point on the membranes, and therefore will cause the rupture of membranes. And in this case, it may be sudden. And remember that why it is dangerous, it's because this is the water that the baby is surviving on. Remember, I put in quote that a baby in uterus is like a fish. So if this water gets out, if we get a reduced amount, then it's dangerous. It can also cause preterm labor. It can significantly increase the risk of infection. It may happen. It may not be caused by an infection, but when it happens, it will create room. Now, remember, there is one way. Okay, one importance of the membranes is that they prevent infections from passing through to the baby. And now, when they have broken, it's like there's a broken barrier, and therefore the infection causative organisms will be able to pass through. There's a note there that occasionally urine leaking from bladder can be confused with amniotic fluid leaking out. Now, what happens is that in the third trimester, or when the mother is almost about to deliver, the weight on the uterus is okay, the weight on the bladder is quite much. And I had talked of frequent micturition. So sometimes the mother will be running to pee, but it happens along the way. And also during that time, because of the hormones I had talked about, there is a hormone called progesterone and relaxin. They causes relaxation of the muscles. So you realize the woman may be trying to tighten those muscles to avoid peeing on the way, but because of the hormonal effects on the muscles, she will not be able to like hold tight. But now, how we differentiate the leaking of membranes and the leaking of urine is that however much a woman would try to hold tight for the leaking of amniotic fluid from happening, you realize that this fluid is not coming from the bladder. It's not passing through the urethra. With the urethra, she can kind of try. This woman will be able to try and squeeze those muscles and be able to prevent the urine from running out. But with the membranes broken, the amniotic fluid, there's no way a woman can be able to control. So it will be a flow. It will be a continuous flow, unlike the urine. Then with this, the doctor will do a test to determine the origin of the fluid, and that's so easy. That's so easy to tell where the leaking is, whether it is urine or whether it is the leaking of LICA. We continue. I'm so bad. We have a danger sign there: headache or blurred vision. This could indicate pre-eclampsia. It could indicate pre-eclampsia. Pre-eclampsia is where the mother suffers. It's like hypertension per se. Okay, there's that chronic hypertension, but pre-eclampsia happens mostly in pregnancy and happens before 20 weeks. And so it's characterized by headache and swelling of the legs. There is also and when I talk of the legs, is the lower part of the legs. We call it pedoedema, and there is also proteins in urine, and also then the BP will be high. Headache and blurred vision can also be as a result of hormonal imbalances before the mother adapts to the imbalances. It could also be caused by diabetes mellitus, that is what we call DM. Then I have a point also there that it could be caused by high blood pressure and protein in urine. Protein in urine basically indicating kidney involvement. There should never be protein particles in urine. And so when it happens during pregnancy, it's a sign that not even in pregnancy, anytime there is proteins in urine, that means the kidneys have are affected because of a certain cause. Not necessarily this, but mostly it's because the BPs are high. It's very dangerous. This is very dangerous for both the mother and baby, as also any other kind of danger sign in pregnancy. We can continue. Pre-eclampsia and toxemia. Pre-eclampsia is a complication. Sorry, no, it's not that. Preeclampsia and toxemia. I had tried to explain a bit about preeclampsia. Said it's high blood pressure with severe headaches, swelling of the feet, ankles, face or hands, and blurred vision are some of the signs of preeclampsia or toxemia. It usually happens after 20 weeks of pregnancy. I had talked about that. Delivery of the baby is the best treatment. This is because when preeclampsia complicates, we get something called eclampsia. And eclampsia is characterized by fitting with fits, those epileptic fits. But now this will not be epileptic fits. These are fits, but not epileptic. And we'll be able to tell this because of the history that we'll take from the mother. And maybe this is a woman who is already under management in a hospital. And so when the fitting happens, what happens is that the supply to the baby is cut during that time of fits, and therefore during that time we know that the baby has not received enough of the nutrients, and what the baby is receiving via the cord is oxygen. Another thing that happens is that also the oxygen supply to the mother's brain is also affected, and so when in case of any complication we have to deliver this baby. And that's why we are saying that if preeclampsia persists, then we have got no other option but to deliver the baby. And earlier I had said that sometimes the baby will be delivered not because it is term, but because we are minding the health of the mother. We don't want to lose the mother. Sometimes, there's how it is weighed medically, and most of the time the mother will be given the chance to live, and the baby will be surrendered. The bed rest is advised at home or in hospital until the blood pressure goes down or the baby is ready for delivery. Remember, now with this one, it depends with the reading of the blood pressure. If it is high, this mother will be managed in hospital. Even if it's for the remaining 4 months, the mother will be kept in hospital. Close monitoring by health providers is needed until the baby is born. If untreated, preeclampsia can lead to eclampsia. I had said that. And eclampsia presents with very elevated blood pressure and seizures and protein in urine. I think I had talked about that. We continue. Reduced or no fetal movement. When the baby is in the uterus, it keeps on moving. Babies do sleep while in uterus. That one we have to note that babies really sleep. Some books or some books and some materials will say that 90% of the time the baby is sleeping, but still the baby will kick. There are times the baby is awake, and these times the baby will also kick. So when your baby is unborn, when an unborn baby suddenly move less or does not move at all, it's a cause for alarm. The alarm may be that the baby may be in distress. It's important to count how long it takes for the baby to kick. some babies will kick maybe approximately 10 times in 2 hours. I want to emphasize that it's good for an individual to note how the baby kicks, because babies will kick differently, depending also on the preoccupations of the mothers. Now, I imagine a mother who is like, if we to compare a teacher who is standing in class and is exhausted and is talking and is stressed, maybe with like 60 students in a class, this baby will kick, but the mother will not notice. And like maybe somebody else, maybe a secretary who is seated just typing a few things, this baby will kick and she's able to notice. So it's good for an individual to monitor how the baby kicks individually, because then with that, any change will now cause an alarm. Any noticed change with the kicks now will tell this woman to go to hospital, or are things okay? Is it still okay, or it's the normal one, or is there cause for alarm? Then dramatic decrease in the number of kicks or longer than 2 hours to perform 10 kicks, it's cause for seeking for medical advice. But again, I said it will depend with individuals. And also at the gestation, you realize that in the first trimester, below 20 weeks, some women will rarely hear the baby's kicks. Actually, the baby's kick starts around 19 weeks, 20 weeks. But now with the third trimester, the babies are term, and therefore we expect that they will kick more than the in the first trimester. And again, if the mother is carrying twins, she also has to note again that there may be many kicks, but it's this one baby, this baby that is kicking. After that baby, another kicks. So she also has to monitor how both babies are kicking at different times. We can continue. Katile, we continue. Persistent lower back pain. This mostly happens because of effect of progesterone and relaxin hormones. I had said about it that these two hormones, progesterone and relaxin, will cause the muscles to relax and to get loose a bit. And so what happens with the back muscles, once they are loose, they kind of will not hold the spine as tight as a pre-gravid time. And so this mother, because of that, now the relaxation or the loosening of the muscles, this woman will suffer backache. There's also the pressure of the growing uterus on the nerves. Most women relate to having lower back pain at some stage during pregnancy. That is very common. I think every mother who has delivered will go through this, and especially during the third trimester. It can be a result of kidney or bladder infections, and that's why we are saying if it persists, there's that normal one that will happen with the rest. It will be manageable with some mild painkillers. It will be manageable. But if it persists, remember, the key thing is danger signs in pregnancy. So if it persists, it's that continuous. The mother has tried relaxing. The mother has tried bed rest. The mother has tried some mild painkillers. The mother has tried some massage, change of position, even when sleeping and when sitting, and it's still persistent. Then it's a danger sign, because as you can see there, it could be kidney or bladder infection. It can also be a sign of preterm labor, which may present with a persistent back pain. And that's why I'm saying if it becomes persistent, medical help is very, very important. Oh, well, now there's something called hyperemesis gravidarum. And I had it mentioned was it last week or it's on when this week, I think on Monday. Hyperemesis gravidarum is characterized by extremely severe ongoing nausea and vomiting. We usually talk of morning sickness in the early months, the first trimester. The first trimester is the first 3 months of pregnancy. We talk of nausea and vomiting, and that the mild one is the morning sickness. The mother will wake up in the morning, doesn't feel like eating, pukes a bit today, pukes a bit tomorrow, doesn't puke the next whole of next week, able to eat, able to retain. But now when it becomes severe, we call it hyperemesis gravidarum. And with this one, the mother doesn't retain anything. She takes water, she vomits, eats fruits, vomits, like she's completely not able to sustain anything. That's the severe part of morning sickness. And the why it is dangerous is because it can cause weight loss and dehydration, basically because this woman is not able to retain anything, not food, not water, and therefore we end up with weight loss and dehydration. The mother and the baby get less of the needed nutrients, self-explanatory. It may require hospital admission, intravenous fluids, that's what we call kuwekwa maji, then not eating or drinking for a short time or to rest the stomach, then slowly starting to eat foods. So this is this is what will be done. Even you realize that even in hospital, this woman will also need to eat, because intravenous fluids don't give as much of the nutrients that are needed, like eating food. So this woman will be advised to eat little by little, very little by very little, but of course balanced, so that the stomach can be able to rest, as we also manage. And she's also put on medication to try and control the vomiting. So this is something that is managed in hospital. We can continue. Preterm labor. Preterm labor, this is labor that begins between weeks 20 and 37. We talk of a term baby. A term baby is the one that is at 37 weeks and above. So if labor happens before 37 weeks, we'll call it preterm labor. And why we are saying that it's a danger sign is because if this baby comes out, remember it's not a term baby. So if this baby comes out, its survival outside the uterus, survival rate is lower. We call it the prognosis. It's lower than when the baby is in utero. The signs of premature or preterm labor include contractions, either painful or painless, that occurs more than 4 times in an hour or less than 15 minutes apart. Then there's pelvic pressure, basically because the baby now, if it is preterm labor, there will be pelvic pressure because the baby has is trying to go down to pass through the birth canal. Then there is low or dull backache. Mostly with labor, what happens is that it starts at the lower part of the abdomen. We call them lower abdominal pains, and then they radiate to the back from the lower part of the abdomen, then goes around the back. We say lower abdominal pains radiating to the back. So by the end of the day, even if it's preterm labor, the back will be involved. And then there is increase in or change in color of the PV discharge. You realize that during pregnancy, as I had said with the first slide, is that we don't expect any bloody discharge, any blood discharge. But in labor, when labor sets in, there's some bloody discharge that happens because at the cervix, if you can remember the images that we had seen, the part that I said it's the cervix. During pregnancy, the cells around that part produces something called the operculum, and it covers the cervix. So during labor, that thing comes off, and it is bloody in color, not blood, bloody in color. So when you say that there is increase or increase in or change in color of the PV discharge, that means the operculum has dislodged and it's coming off, and it's a sign that the cervix is opening. Then abdominal menstruation-like cramps may set on. The contractions are the labor pains, the labor cramps can be managed by drinking 2 or 3 glasses of water or juice, or lying down with feet elevated. But remember now, if this is labor that has set in, sometimes labor has gotten, there's that level of labor that it reaches that there's no going back, there's no reverse. The baby has to be born. We measure with centimeters. Mostly when we go beyond 4 centimeters, then there's no reverse. If the symptoms do not go away in 1 hour, medical help is advised to stop contractions. Yes, there are. And I it's not in the active phase of 4 centimeters, we are able of there are some medications that contractions, and therefore the app, if you could somebody's hand was up.
Nathan.
Okay, we continue. We can continue, if okay. Okay, my last slide, I'm not sure. Okay, I thought it's maybe, I think it's the last slide. Infections. Infections are a danger sign in pregnancy, and this is how they are characterized. They are characterized by fever, especially if it's above 38 degrees Celsius, or last days or longer could be a sign of infection or illness, and this could be an infection. Sometimes it could be as things like urinary tract infections, which can be severe and can also lead into preterm labor. Then it can trigger, okay, this is just the next slide there, the next point there, it can trigger premature preterm labor. The infection may need to be treated with antibiotics or other medications. You also realize that there are some infections that can be transmitted from mother to baby, and therefore it's very key in case of these characteristics of infections. There is the fever, there is the tiredness. There are some that will come with the sweating. You know, there are some that will come with the vomiting. There are all these signs of infections. Then it's good for this mother to seek help, to seek medical advice, and I have put there in capital red that no self-medication. It's very, very important that when a woman is pregnant, don't do self-medication. Don't ask somebody else. Don't go to FB. Don't go to a WhatsApp group to see what happened and post there, I'm feeling like this and this, what should I do? Go to hospital. See your midwife, see. You better even visit that clinic, that your nearby clinic, other than doing self-medication. You could take a drug that can affect your unborn baby. You can also take a drug that will not work well with you and cause more injuries than good. And I think that was my last slide, if I'm right. Yes, and that's what I usually tell people, that pregnancy is so beautiful and no mother should die when giving birth. Thank you. Maybe we can look at the questions if there are any.
Thank you so much, our speaker. I think I can read out the questions from the chat
Yes.
box.
Okay, please read.
Frederick Haura was asking, can a mother with visible bleeding problem be fixed?
Okay, I said depends with the cause. Remember what we said Placenta Previa, where there was very profuse bleeding because of where the placenta was. And we said there are some, you remember, if you could go back to that slide. If you're able to go back to that slide. Yes, there. You have passed it. Peter, go back. That one. That the 4 images. The 4 images. Yes, those ones. Now you can see with the complete previa, if the mother starts bleeding there, the bleeding will be so profuse. And so most of the time what will happen is that we will have to deliver that baby. The reason is there's no way we can suture that part or stitch in layman's language. There's no way to stitch that part to stop bleeding. So sometimes, most of the time, we might end up getting that baby out, because the more we delay, and especially if this mother comes with that kind and she's already in labor. So we will not buy any time. We'll deliver that baby so that we can also save the mother. With marginal previa and low-lying previa, if the bleeding is not much, then something like bed rest can help. Well, there are some medications that will also be given. If maybe it's the labor that was setting in, there will be some medications that will be given to knock off labor. There are also some medications that are given to increase the clotting of blood, so as that the bleeding may not be as much. To just try and see if we can save this baby. Is there any other question?
I have a comment and a contribution.
Okay, thank you.
Number one, that was a fantastic presentation. However, I apologize that I joined late, but at least I managed to get almost 80%.
Thank you.
Now, my comment that I like 2 areas you have mentioned, and I wanted to reinforce this. Number one, pregnancy, let's not encourage or advocate for self-medication, because again, I've seen this is on the rise in low, especially this part of the world where low middle income countries, where you find majority of the smartphone, the Dr. Googles of this world and the chamas who assume, okay, in my during discharge, this is a UTI, I need to take an antibiotic, not knowing that some of those antibiotics can induce abortion or can have a detriment. So there, we emphasize that for the purpose of us who are learners, please, it's true that when you are during that period, no any amount of medication should be self-administered, including through the phone. If you can run to the nearby health clinic, you are safe. Now, on placenta previa, it's a huge discussion, and it's something which is ongoing now. A lot of studies are being done in that area, because in the maternal mortality area, I think it's one of the causes of the postpartum hemorrhage.
Yes.
And sometimes get worse, especially if the clinician who is handling the woman is not aware about it. Because remember, the placenta is already attached inside. So you just pull and it's like you have opened valve. It's like a pipe which has been burst and the pressure is in the pipe. So I've seen most of the time you find people get panic, the woman get panic, the clinician, sometimes the ambulance is not there. So basically, it's very critical that when a lady starts seeing, if you are pregnant and you see any discharge perspective, please don't ignore. Rush to the gynecology, be open to your gyna. You have seen spot of blood, you are pregnant, you are this week, but you are concerned, so that it's able to be addressed, because sometimes you find they are coming late, and when they come late, for example, because maybe because of that, you find they have now to be torn between saving the mother's life and the baby.
Yeah.
So at that time you are told in this part of the world, you'll find there's some culture. They will tell you cannot do this. Where is the husband? The husband is in the village. And here we are dealing with saving life. You see?
Yes.
So it's good to emphasize on clinic visit, open discussion with gynecology, especially so long as you're pregnant. During pregnancy, it's a journey. So that pregnancy journey from day one up to the final life birth or the good positive outcome is very critical for people visiting the clinic. But otherwise, I think it was really a nice topic, and I learned a lot on the personal level. And thanks to everyone.
Thank you, welcome. Yes, as you have said, the major cause, the number one cause of maternal deaths in the world is postpartum hemorrhage. And one cause of postpartum hemorrhage is prepartum hemorrhage. That is that bleeding antenatally. And as we have discussed, one of the causes is placenta previa and placenta abruption. So any cause, a woman who bleeds during pregnancy, there's a high chance that this woman will also bleed after pregnancy. That's why it's such an alarm. Any other question? Or
in fact, I was reading a document published by WHO. We are surprised. I was surprised that in sub-Saharan Africa, actually, PPH is killing women more than malaria. Actually, I think it's top 1 or top 2. It's killing people. It's killing women more than the maternal cases, the mortality cases of malaria in sub-Saharan Africa. And what you find out is that is that aspect of number one, no consistency in terms of clinic visits. So the way you have put it clearly, that if, for example, we are an high-risk patient, you can pick during a natal visit. You can definitely know this will require you to be here a day before the normal labor, so that we monitor you. Because we are likely, chances are very high you like. So you find I was actually it put into an area of, even at personal level, I'm very interested in doing a lot of literature review, because now that is in sub-Saharan Africa is even worse than malaria. You can imagine that that hemorrhage is worse than malaria in this part of the world. You know, that's a concern. Yes.
But that is very true. I can concur with you. I worked in a place where they use concussions. Once a mother goes into labor, they would use these herbs and they would give the mother to drink. And then the mother would be accompanied by a team of women, and they would come running. And you place that mother on the delivery bed.
Traumatized already.
The woman, like she's the cervix is not fully open, but she'll have to deliver because of the power behind the concussions. So you end up with a torn cervix. Some noise back there. You'll end up with a torn cervix. You'll end up with perennial tears, and you'll end up with atonic uterus, because this uterus was not even given a chance to contract regularly and rhythmically for the baby to come out. So it was forced, and that force, I'm telling you, it's like a burst tire. And of course, most of the time we would lose the baby. So I think a lot needs to be researched on, but I can concur with you that postpartum hemorrhage is killing more than malaria in some areas. We can continue.
Well, that was a wonderful discussion, Edin and Tan. I think I've heard and I've learned something. There's a question from Halis Meshak. Is there any medication that can be given to stop the bleeding in placenta previa?
I say it depends with the degree. Like if it is the complete one, these chances are very low to save it. But if like it's the low-lying one, we can try some medications, and mostly it's to knock off labor. I think I can answer that as brief as that.
Thank you. I hope Alice, you answered. Anyone else who has a question? I think most of us, it's a learning process, and that's why they're not asking questions. Alice, your mic is on.
I have no question.
Okay, thank you. For me, I can say I can really appreciate the speaker for that wonderful information that she has shared with us, and I hope we are learning, and as we end the session, we'll be knowing more about the danger signs of pregnancy, and we'll also go and share with others. So thank you so much, our speaker. Maybe I can give you some minute to say your parting shot as we invite our next speaker.
Okay, my parting shot is on importance of antenatal care. Initially, the WHO had talked of 4 visits. You know, the kind of WHO is the one that controls us on what to tafanya, including the vaccines, including as simple as COVID. You'll still hear WHO said. So initially, they had emphasized on 4 visits. But now, currently, we are doing 8 visits, and we are encouraging mothers that the first visit should be done within the 12 weeks of pregnancy. So once a mother discovers that she's pregnant, at least within the first 12 weeks, should initiate antenatal care. And at least we are even calling them contacts, at least 8 contacts. Let this mother be seen in hospital by a midwife or by a nurse or by a gynecologist at least 8 times. With this way we'll be able to see or to diagnose a minor ailment that could progress to a danger sign in pregnancy. So mine is let's embrace antenatal care. Thank you very much. And thank you also for giving me a chance to do this. I love it.
Thank you so much, and yeah, happy and really appreciate that. Maybe we can use a thumbs up to show the speaker and appreciation as we welcome the next speaker.
Thumbs up, thumbs up, thumbs up. That was me.
Okay, thank you so much, Anne Beatrice, for that wonderful session, and thank you all for appreciating the speaker.
Kuna mwingine amenifea fire.
Thank you so much, and welcome. I think we can go to the next speaker, and I think we will end the session at 9:15 or around 9:20, so you will be patient because we started late. So on to our next speaker. We'll also be talking to us about one of the danger signs in pregnancy, and our speaker will be Blessing Intore. We'll be talking about hypertension in pregnancy. She's a health promotion specialist working with Blaze Foundation. So welcome so much, Blessing. And I don't know to pronounce your name well, but welcome so much. We are ready to learn from you.
Okay. Good evening, everyone. Good evening, Katili. So the name is Blessing Itoro Itwen. That's my name.
And from which country are you?
From Nigeria. So we started late. I wouldn't want to wait any longer. I don't know if I can share my screen from here, Katili. Is that okay?
Yes.
Okay. So I'll proceed to share my screen with everyone. Okay. So I'll begin by sharing this. So we want to talk about hypertension in pregnancy. I don't know if we can all see that, please. Can we all see that? Please, can we all see that?
Yes.
Okay. So at the end of this session, I expect that we all know what hypertension in pregnancy is, the classification of hypertension in pregnancy, the diagnosis, and of course, the management and treatment of hypertension in pregnancy. And then we just move. I don't know why my screen is like this. Can we see what is up there?
Some words are cut.
Hello, please. Can we see up there?
Yes, we can.
Yes, we can.
Some words are actually cut out. A minute, please. I think I'll have to start all over again with the sharing. Okay. Please a moment. I know I'm actually taking time. Kathleen, maybe I'll have to share this document with you so you can display it from there because some words are actually cut off. Is that okay?
It's okay.
Okay, so I'll proceed to sharing the document with you. I'm so sorry for taking this time. So you have the document there.
Let me see. I've not received it.
I have also forwarded the document to Enoch if he's available to share too. Please, have you seen the document?
Yes, just a minute.
Okay.
I hope you can see my screen.
Yes, I can see your screen now.
You can go on now.
Okay, so for the behavioral objective, I was trying to say that at the end of this session, I expect that we should know what hypertension in pregnancy is. We should also know the classification of hypertension in pregnancy, the diagnosis and the management, and also treatment of hypertension in pregnancy. So we go straight to what hypertension in pregnancy is. So hypertension in pregnancy is when the blood pressure of a pregnant woman is higher than the normal, okay? When the systolic and the diastolic pressure of a pregnant mother is 140/90 millimeters mercury and above on 2 consecutive readings, okay? You're going to take the readings the first time. You're not going to stop there. You have to make sure you take it 2 times to be sure that the first one wasn't a mistake or wasn't just a coincidence. So you have to take it on 2 consecutive times, and it should always be 4 hours apart. So when you take a blood pressure of a pregnant mother and it's 140 or from 140/90 millimeters mercury and above on these 2 readings, that is when you say that this woman is hypertensive. This person has high blood pressure, okay? But then if severe hypertension is suspected, let's say for instance, when you took the first reading and it was actually more than 140, let's say 150/100 or 160, that is when you say it's actually severe. And at that point, you cannot wait for 4 hours. Remember, I said taking 4 hours apart. But if hypertension is suspected to be severe, if you took it and it was 140 or 150, at that point, you're not waiting for 4 hours because you don't know what is going to happen in the next minute. You don't know what is next hour. So at this point, it is always advised to wait for like 10 to 15 minutes. Okay, it should be at a very short interval. The reason you are doing this is so that you can, or the doctors or the nurses can actually administer antihypertensive therapy immediately. So if severe hypertension is suspected, the diagnosis can be confirmed within a short period of time. And also I want us to note that if you're taking blood pressure readings, and the systolic, the number above is actually normal, but the number below is higher. At that point, you wouldn't say nothing is happening because one number is high and one number is normal. No. At this point, hypertension is suspected. That the number above, which is the systolic blood higher and the diastolic blood pressure is lower, is still called hypertension. Hypertension is still suspected as far as it is not normal. And I want to let us know that the normal blood pressure for adults, for all adults, is actually below 120. Let's say from 90 to 120/80. That's when we say that is actually normal. But anything above 120, we'll start looking at you, especially if you're a pregnant mother, would start handling you with care. Okay, so we move to classification of hypertension in pregnancy. Katili, please, the next slide. In pregnancy, we actually have, hypertension is actually grouped in four categories. We have the chronic hypertension, we have the gestational hypertension, which most people call pregnancy-induced hypertension. We also have the pre-eclampsia and the eclampsia. So we move to chronic hypertension. So chronic hypertension is actually when the blood pressure reading of a pregnant woman, okay, is actually 140/90. Now, let's say she has been having this high blood pressure before she got pregnant or before her 20th week. So I'll go back again. If someone walks to the hospital and this person is actually 20 weeks, below 20 weeks, okay, and she's pregnant, I'm talking about pregnant mother now, and her blood pressure is actually high. At this point, we are saying that she has chronic hypertension. And then it always occurs in up to 20% of women of childbearing age. And its prevalence varies according to age. Okay, for women that are pregnant and they're of older age, they're at more risk. And also for Black women like us, we are also at risk. And then if your body mass index is higher, if you're of higher, your weight is on the higher side, you're also like at risk of having chronic hypertension. Now, although women with chronic hypertension, they do well in pregnancy, right? If you can actually control them well, if you can manage the hypertension well throughout your pregnancy, but then we are at increased risks of superimposed preeclampsia. We also at increased risk restriction, placental abruption, preterm birth, and also cesarean section. So any woman that has chronic hypertension is at risk of cesarean section. This one is something we cannot really do without. That's why when a woman comes and we know that you're high hypertensive, we start telling you to prepare for cesarean section because you don't know how we are going to manage the hypertension, what will happen tomorrow, if it's going to go higher or lower. But when you walk in and we know that you're hypertensive, we tell you prepare for cesarean. So please, we go to the causes of chronic hypertension. Actually, please. Okay, now before we go to the causes, I wrote here that chronic hypertension can either be mild or severe, depending on the systolic and the diastolic blood pressure reading. Chronic hypertension is said to be severe if the diastolic and the systolic blood pressure is at least 160/110 millimeters mercury on 2 consecutive readings. So if it is from 140 to 160, we'd say that is actually mild, that is actually severe. But if it's actually below, okay, if it's below the 160/110 or 140, we'd say that is mild. Please, the next slide. So the causes of chronic hypertension, the causes are actually divided into categories. We have the primary causes, which is also the essential causes, and the secondary causes. So the primary causes are basically, Katili, please, I with me. Okay, so the primary causes include your genetics. It includes environmental factor. So if it runs in the family, if hypertension runs in the family and someone is having it, so we could say that that's the primary cause. And also we have the environmental factor. So you can in weight, alcohol consumption, and smoking. Then the secondary causes, Katili, the secondary causes includes diseases. It could be renal diseases and also endocrine diseases, and of course, medication, especially NSAID drugs. It could also lead to someone having hypertension. Please, the next slide. Then how do you manage chronic hypertension? So management and treatment of chronic hypertension, of patients with chronic hypertension, would depend on the causes and the severity of the hypertension. And of course, the maternal compliance, because most women will come to the hospital and you tell them they have hypertension and they will take it so lightly. It happens a lot. They will take it so lightly because it's hypertension. People don't actually see it as something big, but it's actually something big. It's silent and deadly. So the treatment and causes would depend on maternal compliance. would also depend on the presence or absence of organ damage. So it also contributes to how we treat or manage. Then, but however, whatsoever the case is, the goal of the treatment or management is to reduce risks and ensure that the mother and infant are safe at the end of the day. So whatsoever we do, at the end of the day, we want the mother and child to be safe. Then the management plan, if you are managing a pregnant woman that is hypertensive, we use anti-hypertensive medications, mostly methyl-dopa and labetalol. That's the first thing. And the second way of managing hypertension would be lifestyle modification. So if it is not really severe, if the hypertension is not severe and on the mild state, we could actually manage with lifestyle modification. We could tell you to control your weight for the pregnant women. We could tell the pregnant women to limit how much salt they take and also to exercise. And also then for those that are taking alcohol or smoking, management would involve you stopping totally your alcohol consumption and also them smoking. Please, next slide. Then another aspect of hypertension, which is the gestational hypertension in pregnancy. I mostly call it pregnancy induced. Okay, I just had to put the gestational hypertension. So in the course of our talking, I might likely use pregnancy-induced hypertension. So this one is actually defined by blood pressure greater than 140/90 on 2 consecutive readings. Of course, you have to give hours apart. Now, from 20 weeks of pregnancy. Remember, we said for chronic hypertension is actually before the person gets pregnant or before the woman is 20 weeks pregnant. So that one is chronic. But then for pregnancy-induced hypertension, it can only be said if the woman is from 20 weeks. So even if the woman comes to the hospital and she's hypertensive and she's in the 19th week, we only say that that is chronic, it started, but anything from 20 weeks of pregnancy. Now, without the absence of proteinuria. Now, proteinuria is actually the presence of protein in the urine. So if a woman walks to the hospital and her blood pressure is high and she's more than 20 weeks, then after checking her urine level and we are not seeing any protein, we could say that this is pregnancy-induced hypertension, okay? And also, if she does not have any other clinical features such as headache, edema, impaired kidney functions, or thrombocytopenia, we could say it's actually pregnancy-induced. Please, the next slide. So now, classification of gestational, okay, who is at risk? People that are at risk of having gestational hypertension. I like saying that as far as you're pregnant, you are at risk of developing hypertension, any pregnant mothers. But most especially people at risk are first-time mothers with genetic history, okay, if it runs in the family, then women carrying multiple babies, of course, that fact cannot be ruled out. You are at higher risk. Then women younger than 20 years, like 14, all these children carrying babies, they are also increased risk of hypertension. Or women older than 35, they are at risk too. And then women with history of hypertension or any kidney disease are at risk. Then this one, I don't know if I should call it by birth. Every Black women, we are at risk of gestational hypertension. So now classification of gestational hypertension, we have the mild gestational hypertension and the severe. So gestational hypertension is said to be mild if it starts after 30 weeks of pregnancy. Remember I said that gestational hypertension is the hypertension that starts from 20 weeks, right? So now, if you're developing hypertension, you're having this condition after 30 weeks of pregnancy, it is said to be mild. Okay, here the possibility of it advancing to preeclampsia is actually very, very, very low. But then gestational hypertension is said to be severe if it starts before 30 weeks. So now, if you are at your 20 weeks, from 20 weeks to 30 weeks of pregnancy, that point, we are seeing that the gestational hypertension is actually very, very severe. And then the possibility of it advancing to preeclampsia is 50%. So it's actually 50-50 chances. And the woman here will be handled with care. I mean, serious care, because we don't want it developing to preeclampsia. Please, the next slide. So how is gestational hypertension managed? So, like I said, it will depend on the severity and how high the blood pressure is. So women with blood pressure above 140/90 on 2 readings should be admitted and closely monitored in the hospital. But if less, it is advised to be on bed rest at home. Not all women would want to be in the hospital. Nobody wants to be in the hospital, especially a pregnant mother. But if she's having blood pressure above 140, from 150, 160, she should be in the hospital. You have to we try to convince the woman to be at the hospital so that monitoring should be given. And also, if it's lower, then we can advise her to be at home, but on bed rest. Then we start administration of anti-hypertensive medication. That one is sure. We'll give every woman that has high blood pressure methyl dopa or lactodone. Then conducting proteinuria tests on regular basis. This is another way of management of gestational hypertension, because we want to constantly check and see that you are safe, that you've not gone to the next level. Then full blood count and organs tests on weekly basis. Sometimes it might not be weekly basis, it might be maybe on 2 weeks basis or monthly basis, but it has to be conducted. And then regular assessment of fetus. This one we do, it is advisable to do this, especially on women that are hypertensive. You have to do it weekly. Then you plan for early birth before 37 weeks. That is for women with blood pressure 160 and above, and with other medical complications. We tell you, ma, you're going to put to bed before 37 weeks. So you also tell the pregnant woman ahead. Then another way of managing gestational hypertension is through lifestyle modification, exercising, checking of weight, sodium consumption, and eating healthy meals. Please, the next slide. Then any woman that has a gestational hypertension, after childbirth, those women, especially for those that were given methyl dopa, let me say nearly all women that are hypertensive during pregnancy are given methyl dopa. But those, yes, and this methyl dopa, after 2 days of delivery, such treatment will stop. An alternative treatment will be given. Or sometimes we advise them lifestyle modification. So women who were treated with methyl dopa would stop the treatment after 2 days of delivery. And then we do that we advise, that is advised after childbirth, is reduce treatment if the blood pressure falls back to normal or below. After childbirth, since it was pregnancy that caused the hypertension, after you've put to bed, definitely it will fall back to normal. So now, if it falls back to normal or goes below 130, any hypertensive treatment will stop. Then for women who did not take any hypertensive treatment, and then the blood pressure rises to 150 or higher after childbirth, antihypertensive treatment should begin immediately. Let me explain this well. There are women that after they put to bed, they develop hypertension. Okay, after childbirth, we check you again, we cross-examine you before we let you go. If after birth, we notice that this woman has developed high blood pressure, at this point, we start antihypertensive treatment, and we run the treatment till whenever the blood pressure is normal. Please, the next slide. So we talk about pre-eclampsia. I did mention pre-eclampsia, and the other teacher mentioned pre-eclampsia in the course of our teaching. So now pre-eclampsia is actually blood pressure. Okay. By now, I believe we know that high blood pressure is pressure 140 and above, and you have to take it on 2 readings. So now pre-eclampsia is when a woman has high blood pressure and then with the presence of proteinuria. I did say before that protein is the presence of protein in urine. So any woman that goes to the hospital, she gives her urine for testing. So when a woman gives her urine for testing, and we test the urine and see that she has protein in the urine, and then we check her blood pressure, and you see that the blood pressure is high. At this point, we say she has pre-eclampsia. And then pre-eclampsia usually starts after 20 weeks of pregnancy in women whose blood pressure had been normal before. But for women with chronic hypertension, remember, chronic hypertension starts before 20 weeks of pregnancy. For women like that, the pre-eclampsia might start before 20 weeks of pregnancy. I don't know if we understand that. Please, the next slide. Okay. And also, though major pre-eclampsia is diagnosed when a woman has protein in her urine, but then it can also be diagnosed in the absence of proteinuria, but with the presence of the following. If she does not have protein in her urine, okay, but the blood pressure is high, above 140, cytopenia, that is low level of pellets in her blood, and then she has shortness of breath. Also, she has impaired liver function or blurry vision, temporary loss of sight, or she has developed sensitivity to light. If she has all these characteristics with a high blood pressure, you can actually say that this woman has pre-eclampsia, although there wasn't protein in the urine. I don't know if you get this. So pre-eclampsia can be diagnosed with all these things I've listed in the absence of proteinuria. Please, the next slide. So other signs, I didn't really want to put this, but I just had to, because most women have blood. Sometimes it could be said to be normal, but sometimes it's not. So these are other signs that are not really reliable, but could also occur if a woman has pre-eclampsia. This is sudden weight gain and swellings. That is edema, the swelling, especially. Some would even move to the hand. And then the faces. So now if a woman has edema, mostly on the faces and on the face and the hands, then consent should be given. This one would say that she has pre-eclampsia. But for normal pregnancy, edema do occur, but it's mostly on the leg. And also, if she's nauseatic and vomiting and has high blood pressure, we could start suspecting pre-eclampsia, but it will not be, we just suspect it, but we won't say that. Please, the next slide. So I know I would be asked what causes pre-eclampsia. Actually, I don't know. Research, they've not. I did make research. I asked doctors what could really cause this pre-eclampsia, but they keep saying the exact cause of pre-eclampsia is not known. It is unknown. But Many people think that preeclampsia could be caused as a result of improper functioning of the placenta, including insufficient blood flow to the placenta. Okay, research has not really confirmed this, but then for now, I'll still stand at that the cause of preeclampsia is not known, but other things could contribute to it. That could be excess body weight, poor nutrition, and genetics. If somebody in the family had preeclampsia and this other person again is coming to have it, would say maybe she has it because some other person has it, but we don't know the exact cause of preeclampsia. Please, the next slide. So risk factors associated with preeclampsia, like I said, family history, chronic hypertension, age. And then if you're an African, you also had risk, then short or long intervals between pregnancy would also increase your risk of preeclampsia. If it's too short, if it's too long, if it's shorter than 2 years, you're at risk. If it's more than 4 years, 5 years, you're at risk of having preeclampsia. And also, if you're carrying multiple babies, then these are risk factors that associate with preeclampsia. Then we go to the treatment and management of preeclampsia. If a woman has preeclampsia or eclampsia, the only cure is to deliver the baby. Even World Health advised that the baby should be delivered immediately. But other than this, it can be managed. Preeclampsia can actually be managed to when the baby is delivered. But management would depend on the severity of preeclampsia. Now, for mild eclampsia with pregnancy not up to 37 weeks, if it's mild, wait and deliver the baby at full term. Okay, this is if it's very mild. If the mildness is if after checking your urine sample, checking your protein level, and it's maybe +2. Okay, at this point we can manage you when your baby is up to 37 weeks. But if after checking the protein level in the urine and it's 3+, at this point we are not managing anything. We take you to the labor ward immediately. Please, the next slide. Then the woman will be closely monitored. This is for mild preeclampsia. Remember, I said that it can be managed. You can wait till your full term before delivering if it's mild. The woman will closely be monitored either from home or the hospital, and the woman will need to be on bed rest to try and lower blood pressure and increase blood flow to the. Then, of course, antihypertensive medications will be given, then continuous monitoring of blood pressure, then regular urine and blood tests to know if the preeclampsia is progressing. Okay, this one will have to be done every week to check if it's still at the mild state. Okay, you remember we are monitoring the woman, we are helping her to see how far she can go, but then we have to keep testing the urine to see if the preeclampsia is progressing. Another thing is regular monitoring of the fetus to assist the fetal growth and also the heart rate and amniotic fluid. So we regularly check, okay, and monitor the fetus to see the state, to know if we can actually still prolong or still keep you till full term. And also anticonvulsive drugs will be given. Such anticonvulsive drugs, mostly magnesium sulfate is what is always administered. This drug is to prevent convulsion from happening. I don't know if we understand that. Please, the next slide. Then in severe cases of preeclampsia, this one, we are not telling you that we are monitoring you from home. The woman will have to be admitted in the hospital. No matter anything, you come to the hospital for close monitoring. Then if the pregnancy is up to 34 weeks, delivery can take place as soon as possible. Let me explain this, please. If a woman comes in, okay, and she has high blood pressure with protein in the urine, okay, and after checking the urine and the protein level, and it is 3+, and she's up to 34 weeks of pregnancy, at that point, you take her to the labor ward immediately and deliver the baby. But then, if the pregnancy is less than 34 weeks, what we do is to administer, steroid will be administered to the woman, and she'll wait for 42 to 72 hours. Why we do this is so that the lungs and other organs of the baby will be developed. So once steroid is given 72 hours most, to give the baby chance for the lungs to develop fast. A steroid is only given for pregnancy below 34 weeks, and if the preeclampsia is high. And also anti-hypertensive drugs and of course anti-convulsive drugs will be given to the woman to control the blood pressure and prevent seizure or other complications. Please, the next slide. Now, okay, how do we know if preeclampsia is mild or severe? I had said that in the course. So preeclampsia is said to be severe if the blood pressure is 140/90 or below, with the presence of protein in urine, proteinuria. And then if the protein level is not up to 2+, so we say that it is mild. But if the woman's blood pressure is 140/90 and above, and the protein level is high and up to 3+ or even more, and then she has conditions. She has headache, visual disturbance, less urine in less than 24 hours, or she has low level of pellets in the blood. The preeclampsia is actually severe. Then we move forward to eclampsia. Please, the next slide. Okay, so eclampsia is actually, remember we were talking about preeclampsia, So eclampsia is actually defined as the onset of convulsion or seizure. So if a woman's blood pressure is high, a protein in the urine is also high, more than 3+, then she's convulsing, she's having seizure, then that is eclampsia. I want to tell us what happened some weeks ago. So there's this teenage girl that was pregnant. She should be about 14 or 15 years. She was heavy to like 28 weeks. So while coming to the hospital, many people don't take antenatal care very serious. And I like the fact that the other teacher actually made more emphasis on this. She did not come whatsoever. So the first day of coming for antenatal checkup, she had convulsion in the process of coming to the hospital. At this point, nobody needs to tell you that she has eclampsia. Okay, what we do, we actually treated her. So that aside, eclampsia is defined as the onset of convulsion. So any woman that is pregnant and is convulsing is actually classified as a medical emergency. And at this point, immediately you try as much as you can to stop the seizure, because if the seizure continues, it's either the mother will die or the baby will die. So immediate treatment to stop the seizure, lower blood pressure, and deliver the baby. Okay, so you try to make the mother stable and you deliver the baby immediately. Now, World Health Organization recommends prompt delivery of the baby after the mother is stabilized, irrespective of the gestational age. So now what they're actually saying is, no matter what the age of the baby is, this is not pre-eclampsia that you have to check if it's mild or if it's severe. For mild preeclampsia and for severe preeclampsia, you can actually administer steroid. But if the woman has eclampsia, you are not waiting. You're not doing anything. As far as the mother is stable, irrespective of how old the fetus is, you deliver the baby immediately. And also, I want us to know that eclampsia may lead to coma that may last for minutes or hours, depending on the frequency of seizures the woman had. Next slide. So management of eclampsia, like I said, once a woman convulses when she's pregnant, what we have to do is to deliver the baby immediately. But if she's convulsing, right, we administer magnesium sulfate. This is to help cease the seizure, to help stop it from occurring. Then we also administer antihypertensive drugs to help control or lower the blood pressure. Then prompt delivery of the fetus and placenta is also done, but this should be only after the mother is stabilized. You can't deliver because the woman has eclampsia and you're delivering the baby immediately, even when the woman is not stable. No, you have to make sure the mother is stable before we proceed. Then continuous anticonvulsive treatment for 24 hours after delivery or after last convulsion. So even if when she started convulsing, you keep giving anticonvulsive convulsive 24 hours, even after delivery. Then you continue to administer antihypertensive treatment till the blood pressure returns to normal. Then the patient should be fully monitored, okay? Fully monitored, and we have to certify that you've recovered before they discharge such patients. Please, the next slide. I think this should be the end, okay? Prevention of hypertension in pregnancy. Hypertension in pregnancy, we could prevent it. I don't think it can actually be prevented. Hypertension in pregnancy, you don't know if you have it, but what you do is lifestyle modification. So if you're healthy, you try to eat healthy meal, okay, exercise regularly, it will go a long way to prevent it, okay? But it's not really certain, especially for women with risk factors such as family history or past pregnancy, African women carrying multiple babies. At that point, you can't prevent it, but you can only lower the risk of developing it. And how do you do that? By eating healthy and balanced diet, limiting intake, exercising regularly, then avoidance or cessation of alcohol and smoking, and of course, regular antenatal checkup. So this is the way you can actually lower your risk of developing hypertension in pregnancy. I think this is my last slide. Katili, next one. Yes, that is the last slide. So that is it about hypertension in pregnancy. I don't know if we have questions, if we have contributions. This is the time to say them.
Okay, thank you. I think we have two questions. The first question is from Alice. Alice is asking, in eclampsia, is it really necessary that the pregnant mother had pre-eclampsia, or it just occurs?
Okay, if it just occurs, you cannot just say it can't just occur. Okay, you not just sit down and you're having eclampsia. You definitely have the signs. You definitely have the higher blood pressure, and you definitely have protein in the urine. So it does not just occur. It is actually a continuous process, actually. Let's say you have protein in the urine. Initially, it was 2+, and it increases to 3+. At that point, convulsion sets in, which is the eclampsia. So it doesn't just occur. you have to have preeclampsia before developing eclampsia. I don't know if I've answered the question.
Yes, I'm answered.
Okay, thank you for that. Teresa is asking if the woman presents with severe preeclampsia at 34 weeks, do you induce labor?
If she has preeclampsia at 34 weeks, I think I mentioned that from 34 weeks, you induce labor, yes. Most times we put cesarean section, we wouldn't want the woman to push, okay? We just go straight to CS. CS is always advised.
Thank you so much, our speaker, Madam Blessing. I really appreciate that. Maybe we can have someone raise their hand, or if you have a question, kindly. Yes, Alice.
I have a question. In a case where the mother goes into coma and the fetus was not yet delivered, like, do you let the mother stabilize, then you take the fetus out, or you just have to take the fetus?
Please, I didn't get that too. I can't see anyone. Please, I didn't get your question. You're breaking.
I think Alice.
Okay, can you get me clearly? Hello, are you getting me?
Yes, yes.
Yes, I was asking, in a case where the pregnant mother goes into coma while the fetus was not yet expelled. In such a case, do you allow the mother to stabilize first? That's when you take the fetus out, or you just immediately have to take the fetus out?
Okay, at that point, it depends on the baby. Okay, if the baby is still LV, if the heartbeat is still there, you can leave it. But if you check and you see that the heartbeat is dropping, you deliver the baby. The woman is in coma, she'll definitely come out of it. We'll keep monitoring the woman, but CS will be performed if the baby's heartbeat is dropping. Because we wouldn't want the baby to die inside the mom. You know, she's just in coma, she's not dead. I don't know if I've answered you.
Okay, I'm answered. Thank you.
Any other questions from the group? Okay, Caroline is in educative session. Thank you. Maybe I'll choose just 2 people to say a thank you note, and then we'll have a party shot from our speaker. Thank you so much for that wonderful session on preeclampsia and eclampsia in pregnancy. I think it's so educative, and we are learning, and I hope everyone will share with their friends something they have had today. So I'll just choose randomly. Maybe we can have Lucy Migada just say something to the speaker. Okay, Lucy is not able to unmute. Yeah, Lucy.
I don't have anything to say.
We can have Eunice. Eunice, you can say something, and then we have Jeremiah.
Hello.
Hello.
Okay, the session was nice. I learned a lot personally. I've gained a lot, and perhaps it is applicable in my area of specialization. Thank you, the speaker, for the wonderful presentation, and we're looking forward to learning more from you. Otherwise, thank you.
Thank you.
Thank you, Jeremiah. I think we have some comments from the chat box. Teresa is saying it was a great session. Thank you. Lucy, the session was great. I saw someone else. Ali saying really learned a lot. We appreciate that. So thank you so much, speaker, for having your time to take us through this session. Maybe I can give you maybe 2 minutes to give your parting shot.
Oh, thank you so much, Katili, for having me. Thank you for this opportunity to be here. And I hope to do this more often. For my parting words, I would say that we shouldn't take hypertension, even if you're not pregnant. Okay, we shouldn't take hypertension lightly. Like about a month ago, I went for my community development service and we were in a crowd, right? We're just standing, waiting to sign our documents and everything. And a lady fell down and slumped there. Okay, they started shouting, "Where are you, nurse? This. I told them they should just take the girl to a nearby hospital to check the blood pressure, that it might be that our blood. And when we got to the health center, they checked and it was very high. Okay, and she was walking around like some minutes before that, playing, joking, making fun and everything. So hypertension is actually very serious and you won't have signs like every other conditions where you have sign. This one, you don't have sign, it just happened. So what you have to do is to check your blood pressure often, take your health very serious. I know we are all struggling to make ends meet. People are going through a lot, but in the process of all this, we should try to check our blood pressure often so that you know when to take a break, because most people don't just know when to take a break. But if you check and you see that your blood pressure is elevated, you can actually tell yourself, I need a break, I need to take a break. So let's take this very serious and take our health generally serious. That's all I have to say.
Thank you so much. And as the speaker said, let's take our health serious, and in case of any health condition, maybe sudden, we should always go to the nearest health center. I think we have covered everything that we had to cover today, and we had wonderful speakers. If no one has anything else to add, then I think we can wrap up the session. And thank you everyone for attending, and be patient, and I wish you a good evening.
Thank you.
Bye.
Thank you. Thank you so much.